That's perfect.
So thank you, Lisha. So we will be talking today about pelvic floor health, and this subject is extremely important and not very clearly understood by some clinicians and by most women as well. So I thought it would be a very good idea to give this talk to enlighten ourselves with the simplicity of the issue and also the complexity of the pelvic floor health dysfunction. I'll tell you why it is complex. It's complex because pelvic floor is not just about the vaginal area and the surrounding organs. It has got multiple muscles, as you can see in this diagram. So many supports, and Delancey is one of the doctors and a scientist who has modeled the pelvic floor for a better understanding of how complex the pelvic floor is. And as you can see in this diagram, pelvic floor comprises of bones, it comprises of membranes, it comprises of soft organs like urethra, vagina, anus, rectum. It comprises of sphincters, which are like plugs that control the bowel movement and the urinary movement. It comprises of foramina, which are like holes through which the blood vessels and the nerves run, fascial complexes, ligaments, so on and so forth. So that is why it is a complex organ to understand, and there is no one symptom that tells us that this is the diagnosis. So you have to have a very holistic approach to a pelvic floor dysfunction disorder. And when a woman presents to us with, for example, prolapse or incontinence, we must ask relevant questions in order to get to the correct diagnosis and to offer her the best treatment. The two main components of pelvic floor dysfunction for females are urinary incontinence and prolapse, which I'm going to discuss a little bit more in detail. And then at the end of the talk, we'll take questions. I've tried my best to cover quite a few of your questions in the talk to save time, and then the rest will be covered in the question answer session later on. So urinary incontinence, as we understand, is a very common symptom that can affect women of all ages. It is a myth, it's a misnomer that women become incontinent only when they are in the postmenopausal age group. That is not correct. It can happen in all ages, starting from teenage to reproductive age to perimenopause, and then going on to postmenopausal age. Yes, urinary incontinence is not a life-threatening condition. However, it can seriously influence the physical, psychological, and social well-being of those women who are affected by it. Approximately 18 million women in UK suffer with urinary incontinence, and 25% of it can happen in the premenopausal age group and 40% after menopause. We did an interesting survey some years ago which showed that on an average, a woman takes about 7 years of suffering to gather her strength and energy to be able to go to the GP and discuss these issues, because it's an embarrassing symptom. So less than 50% of women who consider incontinence as a problem seek help, because sometimes it's considered as a normal part of aging process, and they just resort to wearing pads, which is not right. And if we can take home one message from today's talk, is that please seek help. If you're suffering, there are ways and means of helping you. The peak incidence of stress incontinence is more in the younger age group, so 45 to 49 years of age, and we perform approximately 8,000 to 9,000 operations per year for stress incontinence in isolation in England. Incontinence is of various types, so therefore one treatment option does not fit everyone and is not suitable for everyone. So again, the importance of seeking a professional help is important to see what type of incontinence one has, and therefore tailor the treatment according to the symptom. So one of the incontinence is called stress incontinence, which most of you might have heard of. Stress incontinence has got nothing to do with mental stress. Stress incontinence means when the abdominal tummy pressure is far more than what the urethra, which is the pipe that brings the urine to the outside. So when the abdominal pressure is far more than what the urethra can hold, then it's called stress incontinence. Urge incontinence is when a woman gets the frequency of going to the toilet and a strong urge and she can't hold to that urge. So urge incontinence happens in about 25% of women, stress incontinence in 30%, and 35% women have got a mix of both these. So mixed urinary incontinence is the most common of all types of incontinence. Then there is something called overflow incontinence, which means when one cannot empty their bladder properly, and they think they've emptied, but actually they're retaining urine, and there comes to a point where the bladder can't fill up anymore and it starts to dribble. So the women she starts to leak urine. That's called overflow incontinence. And there are other types such as functional incontinence, which means due to some functional impairment, a woman might not be able to reach the toilet on time and she leaks. For example, if somebody has got fractures or have got very bad arthritis and can't get to the toilet on time, or mobility issues or paralysis for any other reason. So that's a functional incontinence. So then the treatment for stress incontinence or urgency will not fit for that particular woman. Just detailing a little bit more of what I've just said, in this left white box, I'm trying to show to you what stress incontinence, what happens when one has stress incontinence. So in this left side, it's a normal anatomy of the abdominal cavity, the bladder, and this is the urethra, and this is the muscle that acts like a plug for stopping incontinence to happen. So when the tummy pressure rises, the pressure in the urethra also increases at the middle part of the urethra because the muscle is very strong. So a woman will not leak urine if this is the kind of anatomy. Whereas if this muscle gets weak or disrupted, as you can see here, it's non-existent. So when the tummy pressure rises, for example, when one coughs, laughs, sneezes, when there is pregnancy, then this pressure is far more than the weak urethral pressure, and this gives way to the urine. So this is the mechanism of stress incontinence. This is the mechanism of overactive bladder, which means that the bladder muscle is overactive. So I've tried to highlight it with these arrows here. So normally this muscle has to be a bit quiescent or quiet or not as active when the bladder is being filled. But women who have overactive bladder symptoms, this muscle just contracts all the time prematurely, giving you one a sensation that they need to go more often for a week, even if there isn't enough urine in the bladder. So what can be done about incontinence? So start off with pelvic floor exercises. Pelvic floor exercises do work, and the mechanism of pelvic floor exercise success is that it increases the muscle tone of the pelvic diaphragm, and thereby it increases the urethral closure pressure, which I just showed in the previous diagram. It also strengthens the other muscles around the urethra and the bladder. Therefore, it works not only just for stress incontinence, but it also works for overactive bladder. It also works for prolapse. We won't lose anything by doing pelvic floor exercises. It might not be the sole cure for everyone. It can cure incontinence in fair percentage, but not in everyone. So it is worth doing it as a first-line treatment. Other important thing which we usually forget even as clinicians is treat the risk factors, because if one has got high BMI, then the abdominal pressure will be high. So no matter what you do to the urethra to strengthen it with surgery, with plugs, with pelvic floor exercises, it won't be as effective if the weight is still high from the top end. Constipation increases the tummy pressure, so we must alleviate constipation. If one smokes and has got bad chest, then a consideration to be given to improve that if possible. Similarly, women who have got cardiac problems or high blood pressure, and if they are on multiple diuretics, then that adds to the incontinence issue. In addition to these, there are certain pessaries which are called incontinence pessaries. Then these should be offered and discussed with the patient. It's a woman's choice what she wants. And these are devices that can be inserted in the vagina like this. They also come in various shapes and sizes. And this little knob acts like that plug where the urethra is weak. So this is the bladder. This is that urethra, and this is the muscle that is expected to be weak when one has stress incontinence. So if you put the pessary with the knob in the vagina, this plug acts like a stopcock and prevents leakage. After discussing the conservative measures, the pessary, then for stress incontinence, bulking injections can be offered. So there are various surgical options for stress incontinence, and there are various surgical options for overactive bladder as well. So surgical options for stress incontinence would include starting from simple ones. This is the injection treatment. So as you can see, it's been shown here in blue little capsule shape structures. So this is the urethra. This is the muscle that is weak. And the injection is of various types. It can be silicone, it can be hydrogel particles, and these are deposited via a telescope called a cystoscope under direct guidance at the middle part of the urethra close to the bladder neck. And you can put it either 2 or 3 or 4 injections to coaptate or close the urethra to increase the closure pressure in this area. And it's got a reasonable success rate of good 60 to 70%, and even more in more experienced hands. It may need repeating in about 20 to 30% of women. And it's got the least side effects of all the surgical treatment options. The more successful procedures include colposuspension, but it's an invasive procedure. It's a big operation. It can be done either laparoscopically, which is keyhole, or through an open approach. And again, whichever approach we use, we access again the urethra. So the bladder is shown here in this diagram. This is the urethral tube, and this is the pubic bone. And we dissect all the way down to this area, which is a very vascular and very complex space to get into. And then 4 very delicate stitches, 2 on either side of the urethra, are applied, and these are then stitched to the back of the pubic bone. So the whole operation is held by these very fine sutures, and once either these can be absorbable or non-absorbable sutures, and then the scar tissue holds everything in place. The success rate for this, for maintaining continence, is good 85 to 90%. But it's more risky operations. It's more risk of bleeding and hemorrhage and infection and long hospital stay and bladder injury and so on and so forth. So less success rate, less risks, more success rate, more risks. We don't do the mesh slings anymore. So it's been banned for the last 4 years because you must have heard of all the mesh issues. So instead of the mesh slings, the fascial slings are used. These have been in use previously as well, but these were more commonly used by the urologists rather than the gynecologists. So now some gynecologists have also started getting experience into doing these fascial slings. So through the tummy approach, a sheet of the fascia is removed, and then it's harvested in theater and then put through the vagina in the form of a sling, again at this weak part of the middle part of the urethra. So the bladder is here, urethra is here, and this is placed there. And again, with time, with scarring, it plugs this part and helps to keep the woman dry. Now, for overactive bladder, the conservative measures are, or the non-surgical measures are, to drink the right stuff. Avoid caffeinated drinks, citrus drinks, alcohol, fizz, chocolate, things like that. And then after that, there are a few medications that the GPs should offer to the women. With they do come with a side effect profile. And it's very important at that consultation with a woman that the GP should talk to them about what helps, what doesn't help, what are the side effects, what are the benefits, what is their risk profile, because each woman is unique, so depending on their age, depending on what are the medications they're on, what are the health issues they have. Some medications may not be suitable for one woman, where it can be the best option for the other one. So we start off with medications, we start off with correct fluid advice. And then if the symptoms do not improve and she continues to describe the urgency and the frequency to pass urine, then they're referred for certain tests. And if the tests show that they have overactive bladder, then they have various surgical procedural options. Here I'm showing the Botox injection into the bladder, which if you remember from my second or third slide, the overactive bladder. So this is the active muscle throughout the bladder. So again, through a telescope or a cystoscope, we call it, the Botox in dilution is injected at at least 15 to 20 injection points. We try to place it equidistant within the bladder. And it's a very effective treatment option. It needs repeating on an average every 6 months. But it also comes with certain risks, like some women need catheter use, and about 15 to 20% of women, which is not a permanent, in most cases it's not permanent. It can wear off with time. As the Botox wears off, that need for catheter can also wear off, but most women are very pleased with this treatment option. The other option is percutaneous tibial nerve stimulation, and there's a needle that is, in simple words, a needle is used to stimulate the tibial nerve, and this all indirectly then controls the signals to the bladder. We call it PTNS, and this needs to be done every week for good 10 to 12 weeks. And it needs good nursing support. Most units have got nurses who deliver this therapy. And it's a good option. The only downside is the cumberness of it and visits to the clinic every week. Most women do not have any issues with that. So if it's available in your nearby setting, then it's a good treatment option. And moving on to more complex options is called sacral nerve modulation. So again, the sacral nerve, which is the S2, 3 and 4 nerves, which are in the lower part of the spine. These are responsible for transmitting the signals for weaning. And if these are not doing a proper job, then these can be stimulated through the sacral nerve modulator technique. In some units, the colorectal doctors do this procedure. In other units, the urogynecologists do the procedure. And it initially starts off with a temporary stimulation technique, and then the nurse specialist keeps a close eye on the woman and sees whether it's working or not. And if it is working, then a permanent titanium battery is implanted in one of the buttock cheeks to deliver the signals. So there are lots of treatment options available for incontinence, depending on the type of incontinence and other aspects of women's history. Moving on to prolapse, which is again a very, very common presentation, more so in postmenopausal women, but it's not unheard of and not very uncommon in younger reproductive age group women as well. Prolapse means when the pelvic organs come down into the vagina and in some cases protrude outside the vagina as well. It can cause discomfort, it can affect the bladder function, it can affect the movement of the bowel, it can affect the sexual activity. So the treatment is again tailored according to a woman's symptoms and her expectations from the procedure. Many a times, prolapse can be just discovered by a practitioner. So sometimes we get referrals where a woman says, I do not know what prolapse is. I went for my smear test and the nurse doing the test said to me, you've got a prolapse. So I've got this referral. If they do not have any symptoms and if they're not bothered by it, we do not do an invasive treatment, but we should guide them to do pelvic floor exercises, which will not do them any harm and it will prevent the progression of the prolapse. So in addition to pelvic floor training, again, we should look at other risk factors like, constipation, straining, weight loss. Prolapse is a hernia. It's a hernia of the pelvic floor. So we should try our best that the herniation does not get worse. In addition to conservative measures, vaginal pessaries can be offered and surgical treatment option is always there. The option for pessaries is far wider and more with the prolapse. And as you can see here, there are different shapes, sizes. The simplest one and the most common in use is the ring pessary. And there are some rings which have got a little support in it. This is the one that I shown earlier in the incontinence section of my presentation. These are other pessaries which are not suitable for women with who are sexually active for obvious reasons, for the shape of it. Some pessaries need removing before sexual activity, and this is certainly one of those. Ring pessaries are compatible with sexual activity, so they don't need to be removed. So this is the kind of discussion we need to have with the women, because there are lots of myths about pessaries that one has to remove it regularly, one cannot wear it if they can't remove it. you can't have sexual activity with the ring pessary and they cause infections. So these are all myths. So it's important in the consultation that we have with the woman that we discuss all these things. What are normal expectations? What are not normal expectations? What are the signs that should take a woman back to the GP and say, I'm experiencing this, this is not right. But these are very good options. These are risk-free options. And if they are sized properly, inserted by an expert or somebody who's had the training in doing them properly, and they have a gentle approach to offer this kind of treatment, then they do work. And I'll tell you why I say that they do work, and it's a scientific evidence. We've done research on it, and I'll just briefly show you the results of my research. So we recruited approximately 300 women who had symptomatic prolapse. So they had symptoms, they were bothered by it. And all women in my practice, I offer everybody pessary and surgery. It's a woman's choice. They choose what they want. It is my job to tell them what are the benefits of pessary, what are the downsides of pessary, what are the benefits of surgery, and what are the downsides of surgery. And very few, I would say maybe 2 or 3 out of 100 women who come to me, they choose to have surgery from the outset. Most of them opt to have a pessary, which is an absolute sensible thing to do. So in this study, again, equal number of women opted for pessary and surgery. And we did a baseline questionnaire, which is a validated questionnaire. It's not like just asking questions about prolapse and the symptoms. It has been robustly tested scientifically. And this questionnaire was given before we offered them any treatment and a year after the treatment. And this is what we found. So these 2 columns are for pessary users, these 2 columns are for surgical patients, and this tells you whether there was any difference in the outcome between the 2 groups. And these are all symptoms that women present with. This is what was covered in the questionnaire. And if this value is less than 0.05, it means that there is a very significant difference between the 2 groups. And as you can see, none of the value is less than 0.05. So it means that the 2 groups were not different. So this is assessing whether there is any change of vaginal symptoms at 1 year and whether these women were bothered by it. And as you can see, there is no difference between the 2 groups. So pessary is a valid option and should be offered to all women, and she can choose whether she wants it or not. Coming on to surgery, very briefly, there are multiple operations for pelvic organ prolapse, depending on the type of the prolapse, which compartment it is coming from, whether it's the front wall, the back wall, the middle wall, the uterus, the cervix, the bladder, the bowel. What is the quality of the tissue she has, whether there are other factors like a big fibroid or bladder problems along with prolapse. So we have to factor all those things in, whether one is suitable for surgery or not. So age is not a significant factor. It is suitability for surgery, which is important. We sometimes see some 30-year-old women who are absolutely unfit for surgery and some 105-year-old who are absolutely fit for surgery. So age is not a significant factor. These are various options. Vaginal mesh should not be used for surgical repair. However, mesh can be offered for abdominal or laparoscopic prolapse repair with very thorough, robust counseling, giving women all the information that is out there, and she chooses whether she wants to opt for that option or not. And these 2 options are kept in safely for prolapse surgery because they can offer significant benefit in especially selected cases. Women who are not suitable for vaginal surgery, they can still have the laparoscopic approach if they qualify for it. However, mesh should not be used for vaginal surgery like anterior repair or posterior repair or sacrospinous fixation. I'll just show you briefly a few diagrams that will explain how the surgery is done. So the first and the most common type of surgery is called anterior posterior repair. Anterior means the front wall of the bladder prolapse. The posterior means the back wall of the bowel prolapse through the vagina. And as I said, prolapse is a hernia. So normally the muscle support should be covering the organ, but in prolapse, the muscle support detaches and it sits on the sides rather than on the organ. So after very careful dissection through that skin of the vagina, we find out where those detached muscle fascial supports are, and we bring them back in the middle where they belong. So that is called a native tissue repair, which means using a woman's own tissue and using the stitches, which are dissolvable stitches. They are not synthetic stitches. They're not permanent stitches. This approach is called vaginal closure procedure or colpocolysis, and this should only be offered to women who do not wish to retain their sexual potential. Mostly in women who are unfit to have major operation. This can be offered under local anesthetic or sedation. So it's a quick procedure, lesser recurrence of prolapse with this. But most women will not qualify for it if they are in the reproductive age group. So we spoke briefly about the mesh. Excuse me. And these factors are to be considered when we offer them laparoscopic or abdominal mesh. So I would like to end my talk by saying that do not think that there isn't a solution to your problem. Begin your journey, because the only impossible journey is that you never begin. So take your first step, take an initiative, speak to your doctor, seek help, and see a specialist and get your problem sorted. Thank you.
Thank you, Ms. Lane. That was really, really interesting. So I've got quite a lot of questions here. If you've covered it in the talk, we can go on to the next one, but I'll just start off. So my prolapse has stopped me doing many activities. Should I consider surgery?
Repeat the question again, Lisa.
My prolapse has stopped me doing many activities. Should I consider surgery?
So as I said in the talk also, start off with simple things, start off with pelvic floor exercises and then seek help, and there are lots of options. So some women who are very active, they may not qualify for having surgery, because you need to be very careful after surgery, what you can and what you can't do, particularly in the initial recovery time period. And also remember, surgery does not fix the prolapse forever. In 30% of women, prolapse recurs, it comes back. If the risk factors are there, the aging process does not stop, the menopausal process does not stop. So that's why there's a 30% chance. So 3 out of 10 women who have prolapse surgery need another operation in their lifetime, because it comes back. It's not like an appendix removal surgery or a gallbladder removal surgery. You remove it and it never comes back. Prolapses can come back. So if you're very, very active, it's best to start off again with conservative approach, do everything possible, see you can tailor your activities in such a way that the pelvic floor does not sustain a lot of trauma and stress, such as weight-bearing activities and so on and so forth.
Okay. How beneficial is yoga and Pilates for pelvic floor health?
So yogas and Pilates do help with pelvic floor health. However, if one is keen in joining these activities, it's important to talk to your yoga trainer or Pilates trainer, so they can direct your training sessions to the pelvic floor in particular, because not all Pilates classes cover pelvic floor. So it's important to talk to your trainer about it, and they're very good Pilates trainers who can direct you, and then you have to give it at least 3 months to see whether it's working and improving your bladder symptoms and your prolapse symptoms. Okay,
thank you. Could my urinary problems be related to having IBS for nearly 50 years?
Yeah, so it's a very sensible, interesting question. So like the IBS, so it stands for irritable bowel, and the similar component in the bladder is overactive bladder. So I do see in my clinical practice women who have IBS or irritable bowel, they do have overactive bladder as well. So there is some link. Not everyone with IBS will have overactive bladder and vice versa. But yes, there is a certain link between the two. And I've also seen, again, in my clinical practice, that women who, for example, drink certain things like bladder irritable things, that can also irritate their IBS. And once their IBS is well controlled with dietary modification, the overactive bladder symptoms also get worse. So it's important to keep that in mind if you're noticing some irritability of the bladder and you already have a pre-existing IBS. You ought to be even more careful of what to eat, what to drink, and just watch out for foods and drinks that irritate one or the other.
Brilliant, thank you. I can sometimes feel my pelvic floor coming to the edge of my vagina opening. Should I see a doctor now?
Yes. Yes is the answer. So that means that you possibly have a grade 2 prolapse. So prolapse is graded from grade 0, which means no prolapse, to grade 4, which is the worst grade of prolapse. And usually when you can feel it at the entrance, that is when it comes to a stage 2 approximately. So yes, please do seek help, and they should offer you the options that we have discussed in my talk today.
Okay, thank you. Does position change have an effect on the pelvic floor and incontinence, i.e. sitting to standing?
Yes, so women who leak urine from sitting to standing position, that usually happens either with overactive bladder, because the bladder muscle can suddenly throw a contraction. However, if there is a very sudden thrust in changing position, then stress incontinence can do the same. So yes, if one is having dribbles of urine on change of position, it's time to see your doctor. And if it's happening, regularly, frequently, and when you know that your bladder was not overtly full. So if if one is bursting to go and you suddenly stand, you would dribble a little bit. But if you know that it's not burstingly full, it was emptied an hour ago, I didn't drink very much, but then why did I leak when I stood up? Then that means that something has started to play up. So yes, seek help.
Thank you. Can I regain a more functional pelvic floor if I exercise it regularly? And what is the best exercise for this purpose?
So pelvic floor exercises is what one should focus on. And as the name suggests, these are dedicated to pelvic floor. Sometimes, particularly our young women, sometimes consider doing more gym exercises and workouts and think that that will improve the pelvic floor as well. It does not always do that. Some of the exercises can be quite counterproductive, particularly weight exercises, HIIT sessions. And as I said in my talk, prolapse is like a hernia. So you can imagine the more weights you hold, the more squats you do, the more wider the hiatus can get and cause further herniation of the area down below. So everything has to be done in a balance. Everything has to be done gently. Start off with pelvic floor exercises, and then other exercises. The best exercise I suggest to my patient is walking, swimming, cycling. But trying to avoid any squats, any circuit trainings, any boxing, kickboxing type of exercises which pose extra pressure on the lower abdominal musculature.
Brilliant. Is walking good if you have a prolapse?
So walking is good for general well-being, but if one has a prolapse, it does not mean that if you walk more, the prolapse will get better. It won't, because by built, we are two-legged beings. Nature has created us vertically. So when we walk or do anything, so most of hours of our life are spent standing, doing things, kitchen, walking, going to work, so on and so forth. So when we stand, the gravity will pull on the pelvic floor, and you'll feel more gravitational pull and strain. So that's why most women say my prolapse symptoms are worse by the end of the day, because they've done all the jobs in a standing position. So if you do long walks, you'll feel at the end of the walk more dragging, more pulling down, more appearance of prolapse. So it's not that the walking is making it worse, but it will make the symptoms more obvious to you. The longer you walk, the more strain you'll feel. So that's why I usually advise my patients, if you walk, do it sensibly. You can't do 10 miles walk in a go. So, and listen to your body. Your body will guide you. If after doing a mile walk, if you feel the dragging in the lower part of your tummy, stop there, sit, have a breather, 10 minutes, leg up, legs up, support. So the gravitational pull is taken away, and then you can start again. For some women, they do 4 or 5 miles before you feel anything. And the other women do just 10 minutes walk and they feel the strain. So each woman is different depending on how bad their prolapse is. But of course, some sort of exercise, one cannot just be sedentary and sit at home and do nothing with a fear that the prolapse can get worse. So walking is a good exercise, but do it in a graded fashion.
Brilliant. Is it too late after a hysterectomy over 10 years ago to try and improve bladder control?
No, it's never too late. And if you have any bladder symptoms, seek help, speak to your doctor, they should direct you. So no woman should suffer in silence. If you're suffering with incontinence, these are very sensitive issues. Go and speak to somebody about it. They should direct you. So it's never too late.
Brilliant. How effective are Passivies, and what Passivie would you recommend?
So, so I've covered most of it in my talk. So Passivies are a very good, effective option in good hands, in more experienced hands, people who are used to using Passivies and they believe in it themselves, because unfortunately some clinicians don't believe in it also, so they won't offer it to their women in an effective fashion. So yes, they're good options. Try them. You won't lose anything by trying them. And the second part of the question was
sorry, and what Passivie would you recommend?
What Passivies, yeah. So the type of Passivie again is dependent on their other risk factors, their sexual activity, their sexual potential. If they're sexually active, then they qualify for certain Passivies and not others. So the shape, the size of the Passivie is dependent on their history and their examination findings. There's no one formula that fits everyone.
Brilliant. And sorry, I'm just going to welcome Lucy, who's the private patient manager from Duchy Hospital. Lucy's just come to assist us with the questions Q&A. So Lucy, you can take the questions that have come in on the Q&A box while you're there. I've still got a few to ask though.
That's okay.
What does posterior tibial nerve stimulation involve?
So it's a treatment option for overactive bladder, and it stimulates the nerve, as the name suggests, the posterior tibial nerve, and by stimulation of that nerve, indirectly the control of the bladder is enhanced, and it requires regular weekly sessions, either with a doctor or with a nurse practitioner who is trained in doing PTNS, which is posterior tibial nerve stimulation, for 10 to 12-week sessions. So it's an effective treatment for overactive bladder, but not for stress incontinence.
Thank you. Can weightlifting make a prolapse worse?
Yes. So again, if one has got prolapse, it's a hernia of the pelvic floor, the more strain one puts onto that hernia, there is likelihood that it is going to get worse. So try and avoid weightlifting if you have prolapse.
I have a prolapse and I have been advised pelvic floor exercises. I'm in my mid-40s and wonder if surgery would be better, the better option.
So again, the option for this lady would be pelvic floor exercises, offer a trial of Passivies, and then surgery. As I said earlier in my talk, surgery does not cure the prolapse forever. It can come back. And if one has surgery in their younger age group, there is increased chance that in a lifetime, they would need another operation, and subsequent operations are not as successful. So the fresh, natural tissue that one has is the best tissue. So one should opt for surgery. If it's a mild stage 1 prolapse, then one should not go down the surgical route. It causes more problems. So if it is stage 2 or 3 prolapse, then try other options. And if nothing works, or if it is not suitable for you, then surgery is always an option. So my suggestion would be to go down non-surgical routes first and then opt for surgery. But as I said earlier, so non-surgical options are not for everyone, but you won't know unless you've tried it.
Brilliant. Thank you, Ms. Sloan. What are your thoughts on the medication links to dementia for overactive bladder treatment?
Yeah, so this has come up in the last, I would say 4 or 5 years. We call it anticholinergic burden, or ABC. And it's again very important that when offering somebody medications for overactive bladder symptoms, for the GPs to take a thorough history to see if a woman already has got some element of Alzheimer's or dementia going on, whether there are memory issues. So women who are over 70 years of age, there is a link to Alzheimer's and dementia if we start on them on certain medications, not all, but certain medications which have that link to Alzheimer's and dementia. And that link is not a quick link. So if one has taken those medications for, let's say, long term, 5 to 10 years, then the risk increases. So again, we should always talk to our patients, take their proper history. There are two main categories of medications that are used for overactive bladder. One has got the link to Alzheimer's dementia, and the other category has got a link to other disorders like high blood pressure and cardiac problems and so on and so forth. So neither of the medication is risk-free. So if somebody has got cardiac stents in, is uncontrolled hypertension, then they can't have the other medication. But if somebody has already got a background of Alzheimer's dementia, they're 90 years of age, then they can't have the medications that have a link to Alzheimer's and dementia. So again, there is no one answer that suits everyone. It has to be patient focused. It has to be unique to that particular woman, what symptoms she has, what is her age, what medications she's on. And then it is always a shared decision making. Gone are the times when doctors decide for the patients that I'm giving you this or I'm doing this for you. It's always shared decision making, and it develops a very good relationship between you as a clinician and the patient, and develops the trust if you talk to them and tell them why are you not offering that certain treatment option and why you're offering them something else.
Thank you, Ms. Stone. Right, Lucy, should we have a look on the chat and Q&A box?
Yeah, so I've got one question come in to say, can intercourse make a prolapse worse?
No is the answer. So prolapse does not make the prolapse worse. Of course, it's an embarrassing symptom. So most of the times, either women avoid sexual activity because they think it can make it worse, or it causes them some discomfort as well, because of course it's sitting there. But prolapse is a soft structure, whether it's bladder or bowel. It does not damage the bladder with sexual activity. It doesn't damage the bowel either. But if the partner can feel some sort of an obstruction, sometimes they say something comes in the way, but usually that something that comes in the way is pushed away with penetrative sexual activity. So the answer to the question is no, it does not make the prolapse worse. If one is comfortable having sexual activity with the prolapse, and usually with sexual performance, in a laying down position, prolapse goes up a little bit anyways. Most women are okay with it, but they avoid sexual activity either with the fear of prolapse getting worse or they feel discomfort with its presence.
Okay, thanks, Ms. Lane. The next question is, which treatment would you suggest as most effective for overactive bladder?
So there is, again, no one treatment that fits everyone. So always start with simple things, always start with safer things. They do work. They do work. We have to believe in it, both as a patient and as a clinician. So start off with drinking the right stuff, drinking the right type of fluid, drinking the right volume of fluid is also very important. Sometimes women come and very proudly tell me, Ms. Sloan, I drink 6 liters of water a day. I should be very healthy. So I said, no, you're doing the wrong thing. You drink, your body needs 2 liters. If you drink more than that, it has to evacuate it somehow. And it evacuates it by leaking or giving you frequency. So you have to drink the right volume, the right type of fluids. Then you move on to pelvic floor exercises. Then you move on to medications. And if that doesn't work, then you move on to further investigations and tests like urodynamics. And then you move on to procedural options. So it's not by pressure or force, but this is the right order of doing things. And good 60 to 70% of women do not need invasive options, whether it's for prolapse or incontinence. They don't. If they follow other things, symptoms do get better with time.
Thank you. And just lastly, we've had a question come in to say, I've had various pessaries for over 2 years for a stage 3 prolapse, but I get a sore patches in the vagina and I have had ulcers. Is this normal?
So pessaries are a foreign body. They're made up of silicone and they're a foreign body, and they can rub against the vaginal wall and cause friction. So the first and foremost thing to assess is there are 2 things actually. One, is this the right pessary for you or not? If it is too big, it can cause what we call in medical term as excoriation or ulceration of the vaginal epithelium. So one can get those ulcers if it's not the right size for you. Secondly, it's important to see if the vagina has got enough estrogen in it. It's enough lubrication. So if the vagina is dry and then we are wearing a pessary on top of that, then that friction creates ulceration as well. Once these two things are corrected or rectified, you get vaginal estrogen if needed, and you get the right size of the pessary. And if one still continues to get ulcerations, then it's time to rethink whether a surgical option can be considered. So ulcerations are common with pessaries. In good 20% of women, they can get little ulceration, but as long as we know that there isn't anything sinister. So that's why if you bleed or if it's painful, it's important to have an examination to see where is the ulceration? Is it really because of the pessary or is it something else? And once that's all ruled out, is it because of infection? So once that's all ruled out, then you can opt either to stick with the pessary or to go down the surgical option.
Thank you, Sloan. There's a few from on the chat Q&A, sorry. Where can I access pelvic floor exercises without seeing a doctor?
So there are good national resources available on the internet. So you can go on to what I would recommend, either an IUGA website. So it is IUGA, which is International Urogynecology Association website. And on the top bar, there will be information for patients. And then if you scroll down, it will be patient information leaflets, and the pelvic floor muscle exercises is on that. And the second good one is British Society of Urogynecology Association, also called BSUG, BSUG in capital. And again, on that, there will be a patient information leaflet section. So information for patient section, and you can find lots of information on that.
Thank you, Ms. Sloan. I have a rectocele. What advice would you give?
So rectocele is a prolapse of the back wall of the vagina. And again, all the options fit the ones that I've detailed earlier. So start with pelvic floor exercises. Make sure you're not constipated. Make sure you don't strain when you're opening your bowels. Make sure your weight is right. And then you can have the option of pessary or surgery. Again, there is a myth or a misnomer that if one has got a rectocele, they don't qualify for having pessary, which is not correct. So any stage of prolapse, any compartment of prolapse, pessary is an option. Yes, if you don't want to use a pessary, that's fine, fair enough, then surgery is an option as well.
Brilliant. What is the difference between a front and back prolapse? What is coming out?
So the front wall is the bladder. So anatomically, if you think the bladder is like a conical structure, so the front wall is where the bladder drops, and the back wall is where the bowel pops up. So the front wall is what we call a cystocele, which is the bladder prolapse, and the back wall is the rectocele, which is the bowel prolapsing into the vagina.
Brilliant, thank you. I'm just going to check to see if we've got any more.
Nothing on mine, Leisha.
That's a chat. Yeah, that's brilliant. Has anyone got any more questions that they would like to ask Ms. Sloan? No. That's it. So that's been brilliant. Thank you so much, Ms. Sloan, and thank you all for attending this evening. Like I said earlier, and what I've put in the chat box, if you'd like to leave feedback on this event, please click the link, and we hope to see you soon. Take care, everyone. Bye.
Thank you.
Thank you.